So I would like to introduce our first speaker, Dr. Carmen Perez, who is an assistant professor in the Department of Radiation Oncology here at Perlmutter Cancer Center.
So thank you everyone for being here. It's a pleasure to share with you some updates regarding my specialty, breast radiation oncology, from the latest San Antonio conference. I have no disclosures. I figure since this audience is pretty broad, I would just start very briefly trying to explain a little bit more about what I do as a breast cancer specialist. On your left over here, you'll see a diagram that summarizes, the key parts when a woman or a man gets diagnosed with breast cancer. We have to worry about the disease in the gland, we have to worry about disease in the nodes, and there's going to be a tumor, and usually the first step is there's a surgery that happens and takes that tumor out. Then you meet with a whole bunch of doctors, including a radiation oncologist, which basically is someone that is a cancer doctor and uses radiation as a medicine to try to eliminate leftover microscopic disease. So during that visit, we discuss what are the approaches that we can do to do that. We plan your radiation treatment. On the cartoon on the right, this is being illustrated by this machine that's called a linear accelerator. And we monitor side effects and become part of the team that follows you for management of your breast cancer. So you can imagine radiation oncology is a very integral part of that multidisciplinary treatment against breast cancer. And in the most recent San Antonio conference, there were actually very important clinical trials that were reported. And what was nice is that they actually spanned different stages of breast cancer. So there were 2 clinical trials that are on the left of the picture that actually had to do with early stage breast cancer, specifically with something called partial breast irradiation that I'm going to talk to you more about that. And also there were 2 studies, one of them a clinical trial with longer follow-up than previously reported, related to nodal irradiation or treatment of the nodes with radiation. So we're going to start with the partial breast irradiation portion, and I'm going to start by explaining a little bit about what that is. So if a woman has a breast cancer, and let's use this example of a tumor at the left upper inner quadrant, one of the choices is actually to undergo a lumpectomy, which we also call a breast conserving surgery, or BCS. I'm intentionally putting all of these letters over here because you'll see that in the figures. We tend to use a lot of acronyms in those figures. The lumpectomy happens and the tumor gets removed, and there's a scar left in the area where that surgery happened. What's very important to recognize is that afterwards we come in with the radiation and we have to try to eliminate leftover disease. And what we know is that if the cancer does come back, it's more likely to come back closer to where the tumor used to be. And if you look at long series of when the cancer comes back, where does it tend to come back? In 75% of the cases, it is within that same quadrant, and consistently you find studies that show anywhere between 60-75. So that's what opens the door to this concept of what's down here, partial breast irradiation, or PBI, because one of the options is we focus our radiation on that portion of the breast where the cancer used to be, and the other option is actually we treat the whole breast, including that area, and sometimes giving that area a boost. So partial breast irradiation has some benefits. For example, this is basically a CAT scan of when we're doing the radiation treatment. I'm labeling the lungs over here, the heart. The multicolored lines represent the radiation dose going into the area where the tumor used to be. And you can appreciate here that this treatment results in less tissue being treated, and actually usually a lot of more distance from the critical organs such as the lung and the heart. So there's a benefit right there. In addition, it's more convenient because it usually can be completed within a week or 2 weeks of treatment. Now, what's can be very confusing about partial breast is that you can actually, and if you do a Google search on this, you'll find that there are many different ways of doing partial breast. So these are sort of the 3 main ones, and these are the ones that you're going to see in one of those clinical trials that I'll discuss. So one of them is delivered basically with a machine that's called a linear accelerator, or external beam radiation, or in short, you'll see this 3D CRT. And basically it's the same machine that you use to treat the whole breast, you just treat a smaller area. Another option is inside the operating room. along with your surgeon, the radiation oncologist places a device. That's what's called a single brachytherapy. Or you can actually use catheters that get implanted into the breast, and that's interstitial multi-catheter, or MCV. The first trial that I'll discuss it's called, we can call it NSABP B-39. And basically what they did is actually compare side by side the treatment to the breast, to the whole breast, with patients getting treated just to the partial breast. It's a trial that actually was open for 8 years, from 2005 to 2013. You can see that it accrued a lot of patients, over 4,000 patients. And what they reported in San Antonio was a follow-up of those patients for over 10 years. Very important in all of these trials, who are the patients that these results apply to. So these are lumpectomy patients. This is a little bit of an older trial, and it's modern, but all the way back to 2005. And it did include patients that had stage 1 and stage 2 disease, which actually nowadays we would think that it'd be a little bit too maverick to include those bigger tumor patients for partial breast, but it did include those patients. The tumor size had to be less than 3 centimeters. The margins had to be negative, which this cartoon over here illustrates what a negative margin is. If the tumor is in pink, you want a good distance from the edge of the specimen, because otherwise you worry that there's more disease left over in the breast. They did allow node-positive patients, and actually they didn't, other than the patient had to be older than 18, they didn't have an age restriction, which again is something that we take into consideration nowadays for our partial breast recommendations. This is just a schema which shows that stratification means that they were capturing all of these details for all of the patients, and then it's a randomized trial, which is our the best design that we can have to address these questions. And the patients basically got randomized to, as I mentioned, whole breast irradiation, WBI, or partial breast irradiation. The partial breast irradiation could be done in any of those ways that I mentioned before. As mentioned, over 4,000 patients, most of them are postmenopausal, and most of them had hormone receptor positive disease. Very importantly, the majority of patients receive hormone therapy, and this is a theme that you'll continue seeing and it really illustrates how the treatment against breast cancer is really a combination of all these treatments coming together. And most of the patients were treated with the 3D option, the machine that treats you from outside. Second most common was intraoperatively with this device. And the third more common one was the catheter option. And then the whole breast patients were treated to the whole breast, and sometimes with an extra dose to the lumpectomy cavity, which is what a boost is. The endpoints are important because that's actually what the trial gets powered to test. And in this case, the primary endpoint was something called ipsilateral breast tumor recurrence, or what's the risk of that cancer coming back in that breast that received the lumpectomy and the radiation. And secondary outcomes, things that you would expect, such as overall survival and the absence of this distant disease. Now, for this study, I'll break the suspense. It was a negative study, but to understand that, we need to look a little bit into the statistics that they use for the study. In very simple terms, they were testing whether doing this comparison could result in calling whole breast irradiation inferior or partial breast irradiation inferior. If they were not inferior, then they're equivalent, right? So they're looking at something called a hazard ratio, which is when you compare two different treatments, what is the risk of ending up with a local recurrence if you do one treatment versus the other? In order for them to be able to conclude that the two were equivalent, they had to fall within this blue space, okay? Those numbers at the end result of the analysis. These are the results, just looking at them first in a graph format. So each of these graphs are formed by events of recurrence. They were actually pretty low events. So only 161 out of those 4,000 patients, which is fantastic. It's good news because these recurrences are rare, and this is over a period of 10 years, right? And you can see in the pink line are the patients that were treated with partial breast, and the whole breast patients are over here. And you can see that the numbers are very similar. The absolute difference between these two numbers is only 0.7%, okay? However, and that's not statistically significant, less than 5% over those 10 years. However, If you recall that drawing that I showed you before, that number, the hazard ratio and the confidence intervals had to fit within that blue box, and it didn't, right? So technically, they had to report it as a negative trial that didn't show that the two treatments were equivalent. Very interestingly, things that you would expect did happen. For example, in the patients that were treated with partial breast, the majority of the cancers that came back outside of the area that we treated. So it wasn't really that the partial breast was necessarily ineffective, it was just that you're not treating the whole breast. So in conclusion for this trial, because of that statistical, very important detail, they were unable to actually refute the hypothesis that they were equivalent. But it's very important, and this is something that they highlight throughout the presentation in San Antonio, the absolute difference was very small, at 0.7%. So they actually, even though the statistics were negative, they highlight that this partial breast treatment may be an acceptable alternative to whole breast irradiation. And very importantly, I didn't show the data for lack of time, but they looked at all those other events, overall survival, metastasis-free survival, and all of those events were very low, certainly less than 5%, and very similar between the two groups. Interestingly, remember that in this study, they allowed many different methods for doing the partial breast. A very nice subgroup analysis or extra analysis that they did is they decided to look individually at all of these different types of partial breast irradiation. And you see here on the left, I have a little cheat sheet where, this is going to be the red, this is the blue, and then the green is the external beam or 3D, which is, again, the machine that treats the whole breast, just treats a smaller field. And if you look at that, the 3D machine compared to the whole breast option, they're very overlapping, right? So certainly this is a subgroup analysis, but it's important because it's suggesting that if we use that technique of partial breast, then it would be equivalent to the whole breast irradiation. And it's a beautiful link into the next trial, actually something I wanted to point out is that is actually the technique for partial breast that we do at NYU, which was very reassuring to see in this very large clinical trial. The next trial that they presented regarding partial breast irradiation actually did exactly what I was alluding to. They limited the partial breast irradiation. It's a trial from Canada, and in all of their patients treated, they used the external beam or 3D CRT technique for partial breast. And half of the women got radiation to just the lumpectomy cavity, that's the APBI arm, and the other half to the whole breast. Just like the other trial, their primary outcome was ipsilateral breast tumor recurrence, and the other outcomes are things you would expect. And in addition, they had a very nice report of the toxicity and the cosmetic outcomes. The inclusion criteria, you'll see here that actually they were a little bit less, they're a little bit more conservative, right? So the size is the same. The size limit was 3 centimeters, but they only allowed patients that were negative, and patients that were younger than 40 years of age were excluded. So this is closer now to what our guidelines state are, patients that are adequate for these partial breast treatments. And you can see when they report the patient characteristics, the two columns between the two groups, because they stratified, they're very nicely balanced, but I'm drawing your eyes to some key characteristics of the patients. So the tumor size actually, in the majority of patients, was less than 1.5 centimeters. And again, the majority of patients received that additional treatment of anti-estrogen therapy. This is just illustrations of how these two treatments differ. Remember, they're both getting treated with the same machine. The whole breast irradiated patients, you can see that the radiation, if you can see it going through the skin in purple here, it's including a bigger area. And the line in yellow over here highlights the whole breast is getting treated with the radiation. And this is just going over some details regarding the dose, which are pretty standard for whole breast irradiation. For partial breast, however, this tumor, for example, is in the inner quadrant, and you can see that the radiation dose gets optimized to cover that area and spare the rest. As mentioned, they assess not only for the disease control outcomes, but also cosmetic results and toxicity. So this is the actual schema where it's a little bit smaller than the other trial, but it's still 2,000 women, over 2,000 women that participated and got randomized into the two arms. So these are the results. So as you can see, first of all, again, the number of events was very low. The follow-up for these patients was about eight, close to 9 years as well. And you can see that, the graphs are very, very overlapping to a point that you can barely see a difference, right? So they go ahead and zoom in. And once you zoom in and you're in a scale from 0 to 4%, you can see that, there were very little differences between the two arms. And in this case, those the fancy statistics to be able to statistically say that something is non-inferior actually worked out, because for the way that they calculated it, the hazard ratio could not, the boundaries of that hazard ratio could not be higher than 2.02, and they were not in this case. So this is the first time that they're able to show in a head-to-head comparison between whole breast and partial radiation using external beam that they're equivalent treatments and with very low risk of recurrences, actually in this case about 3% or less. And no difference in the other outcomes as well. Nicely in this study, they reported side effects, right? Because that's the other side of the coin that we need to look at. As expected, when you treat the whole breast, which is in red, during the treatment, you end up getting more acute side effects, such as the reaction of the skin, which is called dermatitis, as well as swelling. However, what was a little bit concerning was that as for the late effects, you can see that that shifts. And actually the blue, which is the partial breast treatments, end up getting more reports of fibrosis or induration of the breast and skin telangiectasias, which are superficial capillaries. That also matches the results when they look at cosmesis. And basically the top and the bottom are reporting the same thing, except the bottom one, which is where I'll draw your attention to, are cosmetic results reported by the patient. They're concordant. In general, the patients tend to report a little bit more dissatisfaction than when a clinician does the same assessment. But the trends were the same. I want you to look at the orange bars, and basically what it's showing, that orange is patients that reported their cosmetic outcome as fair or poor, okay? At baseline, they're very similar between the partial breast treatment and the whole breast treated patients, but as the years go by, you can see that the whole breast treatment, it's only about 15% versus there's an increase in the partial breast treatment, raising the concern that because of this more focal radiation, higher dose, and a twice daily regimen, there might be a price to pay regarding that, the effects locally on the breast. So in conclusion for this one, they were able to show it that partial breast using this external beam approach was not inferior to whole breast. The rates of recurrence of the cancers were very low, which is great that it was also concordant with the other study. However, the partial breast was associated with increased late toxicity and adverse cosmesis. So because of that result, they're very hesitant to recommend this particular regimen. However, it opens the door for other regimens of partial breast irradiation, such as a once a day regimen, which is what we've been doing at NYU actually since now 19 years, since the year 2000. And actually, when we look at our data, which has been reported, those rates of fair poor is not in the 30%, it's more closer to 10-15%. So that might be a good thing to do, regarding doing partial breast with external beam option, but using a different schedule. Now, shifting gears for the last part of my session, I'm going to talk about the studies that impacted women that have a little bit more advanced disease. So the cancer is no longer only in the breast, but it has actually gone into the regional nodes. When we're talking about nodes, I like to show this diagram just to give you it's artistic, but it's a rendition of what, if you could see the nodes, what they would look like little beans in this case that are really draining the breast. And if you have a cancer in the breast, it can go into these different areas, and we name them differently depending on the location. So there were two questions that were addressed by these big trials reported at San Antonio. The first one is, should early stage patients get regional nodal irradiation? And what that alludes to is, is there a benefit to radiating the nodes even if you don't have 10 nodes positive, but maybe just 1 or 2 or 3 nodes. And then the other study, which is called the Amoros study, looked into comparing basically side-by-side surgery and versus radiation for the treatment of the nodes. So the first study that I'm going to show is a meta-analysis, which is just in summary, we take a whole bunch of studies, they get in a very systematic way put together in an overview, and then conclusions are made about them. So the studies that were taken for these big meta-analysis were actually 14 clinical trials that included over 14,000 women. And this is a distribution of, what all of the trials were comparing women that got treated to the nodes with radiation or not. And then in the majority of cases, they got treated to all of those nodes that I showed you in the picture. What was really nice about this analysis and kind of novel, they haven't done this before, is that they divided the trials between older trials, so women that had been treated in the 60s and 70s, versus women that were treated in 1989 onwards. And that's extremely important because we know that the technology for my field, the technology that was even in the 80s is very different from the technology that's available now. So that was extremely important to do in this analysis. So you'll see that when I show the results on the left, you're going to see the results for the newer trials versus the result for the older trials. When they look at any recurrence of breast cancer in the newer trials, they see that when you do regional radiation, there's a lower risk of recurrence than when you don't have that regional irradiation. The magnitude was small, but it was present and statistically significant. They do not see that. You see the curves overlapping for the older trials. When they look at very important outcome, breast cancer mortality, the risk of dying from breast cancer, the regional nodal irradiation group actually had a lower risk. Again, the magnitude is small at 10 years, 2.8, but it was statistically significant, and they do not see that in the older trials. What they did see in the older trial is that if they look at women that were dying from causes outside of breast cancer, that was higher in those older trials, where you see that women that had that regional radiation were at a higher risk of dying than women that did not get regional radiation. And in a way, it makes sense because it's possible that women were receiving unintended radiation to their lungs and heart, and that could actually affect their outcome. But it was extremely reassuring that in these newer trials, we did not see that difference. And then finally, it was very important to look at whether the number of nodes matter in terms of that benefit from regional nodal irradiation. So we know that if the patient has no nodes that are found positive, then there's really no statistically significant difference, okay? You do see a small difference of about 1.4% at 10 years when the patient has low nodal burden of 1 to 3 nodes being positive. And what was also clear was that there's a bigger difference in the patients that have more volume of disease involved in the nodes with 4 or more positive nodes. So the conclusions from this is that when you look at breast cancer mortality, in the older trials, there's going to be little effect because actually you are sort of, whatever you were bringing to help with the breast cancer mortality, you're bringing down also, with affecting the overall mortality. In the newer trials, there's a significant effect, statistically significant effect, even for the patients with 1, 2, or 3 nodes, but the absolute mortality reduction was greater in the group that had more nodes positive, and it really remains, a clinical challenge to define who really benefits the most from the radiation to the nodes. The very last thing I'll show is this comparison between if we need to treat the nodes, is surgery better or is radiation better? So it's sort of the beam versus the scalpel. The trial is called Amoros for after mapping axilla radiotherapy or surgery. It's a mouthful, but basically it was a study that picked women that had tumors that could be as big as 5 centimeters, but clinically they could not have anything detected in the axilla. They got randomized to surgery or radiation to the nodes only if after they had a procedure called a sentinel node biopsy, that node was positive. So the sentinel node is the main drainer node. If it was negative, nothing happened. That was it, the surgery stopped. If it was positive, they either continued the surgery to do a dissection or receive radiation to the nodes. This is just a summary of the inclusion criteria. Again, it included patients up to 5 centimeters, any age, and the patient population, again, are patients that have that, they don't expect to have a node positive, but are found to have a node positive in the operating room. And very importantly, they look at, what they reported at San Antonio this year is the 10-year outcomes and also not only regarding nodal recurrences, but also side effects such as lymphedema or mobility of the arm. So again, the baseline characteristics are very well matched between the two treatments. And very importantly, the majority get chemotherapy and hormone therapy in both cases. When you get a sentinel node only, of course, you only had 2 nodes removed. When you get an axillary dissection, you get more nodes removed. And very importantly, in those patients that they actually go on and do the axillary dissection, it's about 30% that they actually find additional disease. So that's very important because, basically what this trial is asking is, can radiation take care of that 30% of cases when there's additional disease that surgery has not taken out? So very nicely, basically the 10-year follow-up data looks exactly the same as when they reported it at 5 years. So very low risk of regional recurrence, about 1%. And you can see that the curves are very overlapping at the bottom over there. No difference in disease-free survival, metastases, or overall survival. And very importantly, when they report the side effects, they had really good, the patients actually, about 60-70% of the patients participated in providing this information even at 5 years. And they measure both the quality of the movement of that arm in all of these different directions and also the rates of lymphedema. I'll focus on the rates of lymphedema, which is such an important thing to think about. So for lymphedema as defined by clinical observation, you can see that blue, which is the scalpel, the surgery arm, they always had higher rates, both at 1 year, 3 years, and 5 years compared to the radiation. And if they actually look at lymphedema as defined by getting a treatment against lymphedema, this same trend, was maintained. So the conclusion was that both of them are great and absolutely comparable at protecting against, a recurrence in those nodes from hidden disease. No difference in survival, both disease-free or overall. Diagnosis of the lymph node recurrences, they really, if they happen, most of them happen within the first 5 years. And however, where the radiation was the winner was for less risk of lymphedema after 5 years. And therefore, the conclusion actually from the trial is that radiation to those nodes can be considered a standard of treatment for patients that meet that eligibility criteria that we discussed. So very final slide, just as a summary. So what are some practical applications that, clinicians and you as, patients or, friends or family members of patients can take from this? So again, we discuss issues in early stage as well as more regionally advanced breast cancer. Regarding the early stage, certainly it has to be in everyone's mind considering this partial breast irradiation options, particularly using this 3-dimensional conformal radiotherapy. And it appears to be a good option, particularly for patients that are prioritizing the convenience of the treatment over the cosmesis. And better yet, there's still a lot of research, and we're active on that as well, on using different regimens that still use this type of technique, but over, for example, daily treatments rather than twice daily treatment. Consider nodal radiation instead of a full dissection of the axilla for eligible patients that meet that Amoros trial criteria. And then regarding the issue of treating the nodes in patients that are early stage, particularly that population that has 1, 2, or 3 nodes, it's still, the jury's still out, and really it has to be a discussion with between the patient and the doctor regarding toxicity and benefits. And there's a lot of research going into using additional tools to try to risk stratify patients, and we have some trials open on that at NYU as well. Thank you for your attention.